Imagine this. Your brain sends a crystal clear command to lift your arm, but the message gets lost. It's like a bad connection, and your muscle barely responds. This communication breakdown is the everyday reality for people with myasthenia gravis, a really fascinating and complex autoimmune disorder where the body's own defense system basically turns on itself. So let's dive in and see exactly how this happens.
Okay, so think of your immune system as the super elite security team, right? It's always on patrol looking for threats. But what if that team suddenly couldn't tell the good guys from the bad guys? In myasthenia gravis, that is exactly what happens. The body's defenders launch this friendly fire attack on the critical communication lines between your nerves and your muscles, and that question is the key to understanding this entire disease.
So to really get why someone with myasthenia gravis experiences such profound weakness, we have to go right to the source of the problem. We're going to zoom way in, down to the microscopic space where nerve endings meet muscle fibers. This spot is called the neuromuscular junction, and it's basically ground zero for this whole communication breakdown.
So what is myasthenia gravis, or MG, really? Well, at its core, it's a chronic autoimmune disorder, but the key phrase here is fluctuating muscle weakness. See, this isn't like a battery just dying. It's way more like a faulty electrical connection. One moment the power's on and things work, and the next it just flickers and fades. This unpredictable ebb and flow of strength, that's the absolute hallmark of the condition.
Okay, this slide shows the whole problem perfectly. Over on the left, you see how it's supposed to work. A nerve releases a chemical called acetylcholine. Think of these as keys. They float across and fit perfectly into receptors on the muscle, those are the locks, and click, they unlock a muscle contraction. Simple. Now look to the right. This is what's happening in myasthenia gravis. The body's immune system has created these rogue antibodies that are acting like gum, literally plugging up the keyholes. So no matter how many keys the nerve releases, most of them just can't get in, and the muscle never gets the signal to move.
Let's just walk through this one more time step by step. So step 1, a nerve impulse arrives, carrying the order to move. But look what's waiting for it in step 2. Those rogue autoantibodies have set up a blockade. They're just camping out on all the receptor sites. So in step 3, when the acetylcholine messengers are released, they find that most of the docks are already taken. The result in step 4 is pretty inevitable. The signal fails, and the muscle contraction is super weak, or just doesn't happen at all.
So where are these rogue antibodies even coming from? Well, a ton of evidence points to the thymus gland. That's a small immune organ located right here, behind the breastbone. Now, normally, the thymus is where your immune cells go to get trained, but in a lot of people with MG, the thymus is abnormal. It might be enlarged, or it could even have a tumor called a thymoma. We think this malfunctioning gland is the command center that's giving the immune system these terrible, faulty orders.
All right, we've seen the problem on a microscopic level. But what does this broken signal actually look and feel like for a patient? How do these blocked receptors translate into real-world symptoms?
If there is one sentence you remember from this whole explainer, it's this one. Muscle weakness that worsens with activity and improves with rest. This isn't just a symptom, it is the defining characteristic. A person might feel totally fine in the morning, but as the day goes on, or even after a simple task like combing their hair, the weakness just crashes in. This profound fatigability is the classic sign that doctors are looking for.
And this weakness, it often shows up first in the most delicate, most frequently used muscles. As you can see here, common early signs are things like drooping eyelids, which we call ptosis, and double vision, or diplopia, because the tiny muscles that control your eye movements just get exhausted. From there, it can spread to facial muscles, making it hard to smile, and it can even dangerously affect the muscles you need for chewing and swallowing.
And this is where the disease can get really scary. When that fatigable weakness spreads to the diaphragm and the muscles of the chest wall, the muscles we need for every single breath we take, it can trigger what's called a myasthenic crisis. This is an absolute medical emergency. The patient's respiratory system starts to fail, and they need to be put on a ventilator immediately just to survive.
So, once the symptoms are clear, the clinical investigation really begins. The challenge now is to find the smoking gun, to gather that definitive proof that an autoimmune attack is happening and officially lock in the diagnosis.
The diagnostic process has a few key tools. First up, there's a highly specific antibody blood test that can actually detect those rogue acetylcholine receptor antibodies, confirming the autoimmune attack. Next, they do nerve stimulation studies. This is where they repeatedly stimulate a nerve to see how the muscle holds up. In MG, What you see is a progressive decline in the muscle's response. It gets weaker and weaker with each zap. That's proof of the fatigability, because with each signal, fewer and fewer receptors are available to fire.
And finally, to check out that potential command center we talked about, a CT scan of the chest is absolutely essential. This lets doctors get a clear look at the thymus gland, searching for that enlargement or those tumors that are so often linked to myasthenia gravis. It ties the whole diagnosis right back to a potential source of the problem.
Okay, so with the attacker identified, the focus shifts to the counterattack. Now, there isn't a single cure for MG, so treatment involves a multi-pronged strategy. It's all designed to manage symptoms, suppress that immune attack, and ultimately restore the vital connection between nerve and muscle. The treatment strategy is really layered, moving from immediate relief to long-term control. The first step is just symptom control, using drugs to boost the signal. The next deeper layer is immune suppression, using meds to calm down that overactive immune system. For a lot of patients, surgery to remove the faulty thymus gland is a really key step. And for emergencies, we have crisis management tools that can rapidly clear out all those harmful antibodies from the blood.
Let's look at that first-line drug, pyridostigmine, because it's pretty brilliant. It can't unblock those gummed-up receptors, right? So it does the next best thing. It's what's called an acetylcholinesterase inhibitor, which is a fancy way of saying it blocks the enzyme that normally cleans up acetylcholine. This lets the keys hang around in that space for much longer, basically flooding the zone. And with more keys available for a longer time, the chances of one of them finding an open lock go way, way up, which directly improves muscle strength.
So let's wrap this all up. What are the absolute key takeaways here? First, the disorder. It's an autoimmune attack on the neuromuscular junction. The mechanism: antibodies are blocking crucial acetylcholine receptors. The hallmark: that fatigable muscle weakness that gets better with rest. The diagnosis: it's confirmed with antibody tests and nerve studies. And finally, the treatment: it's a dual approach of improving the signal while suppressing that misguided immune response.
And this all brings us to one final big question. While the battle is clearly fought in the muscles, the war seems to start in the immune system, very often in the thymus gland itself. So you have to ask, is myasthenia gravis really a muscle disease? Or is the muscle weakness just the downstream collateral damage from a much deeper, more fundamental puzzle going wrong within our own body's defense systems?